Okay, so the next presentation is by Dr. Suvarna Yeluguri. Hello, Dr. Suvarna, and she is going to present on comparison of choroidal thickness and lens thickness among subtype of angle closure disease.
Good morning, everyone. Today's my topic is comparison of choroid thickness and lens thickness among subtypes of angle closure disease. Glaucoma is characterized by a group of disease rather than a single disease process that differ in their clinical presentation, pathophysiology, and treatment, which causes irreversible blindness in the world, which was broadly divided into open angle and closed angle. Even though open angle glaucoma is more common, the proportion who became blind due to closed angle is over 25% more. Because of its acute presentation, which is resulting in about 4 million population going to irreversible blindness in the world, thus ranking a second leading cause of blindness worldwide. Coming to primary angle closure disease, until recently it was considered as an anatomical disease because of shorter axial length, flatter cornea, shallow anterior chamber, and thick lens, etc. But it could explain only 1/3 of the variance in the prevalence of primary angle closure disease. So some other factors are also responsible for the development of primary angle closure disease. During the past few years, because of development of advances in the diagnostic modalities, there is a rise in the role of choroid in the pathophysiology of primary angle closure disease. In a study by Singh et al., they had found a correlation between choroid thickness and intraocular pressure in primary angle closure glaucoma in the Indian population. However, they have not evaluated the choroid thickness in different subtypes of the angle closure disease, including primary angle closure suspect and primary angle closure eyes. And also, lens thickness was not assessed, which could be a confounding factor, as increased lens vault is a risk factor for angle closure. The purpose of this present study was to evaluate the choroid thickness and lens thickness among various subtypes of angle closure disease and compare them with healthy controls. It is a cross-sectional study, cross-sectional observational and comparative study. Institutional committee ethical committee approval was obtained, and study was conducted at our eye hospital between June 2022 and Feb 2023. And inclusion criteria is based on International Society of Geographical and Epidemiological Ophthalmology, primary angle closure suspect, primary angle closure glaucoma, and a healthy controls comprising of eyes with baseline intraocular pressure less than or equal to 21 mmHg, open angles on gonioscopy, and normal optic disc. Exclusion criteria was patients less than 30 years of age, secondary glaucoma, anterior segment pathologies like conjunctivitis, keratitis, or uveitis, and history of opaque ocular media, ocular surface disorders, ocular surgeries, and ocular trauma, and other ocular diseases such as retinopathies and choroidopathies, or systemic diseases that may affect the vision. For the subjects who fulfill the inclusion criteria after complete ophthalmic examination, lens thickness was measured using an automated optical biometer. 3 measurements were taken, and an average of them was considered for analysis to minimize the bias. Choroidal imaging was done using enhanced depth imaging OCT. The scan used for viewing the choroid was HD cross 6 mm line EDI mode, and the images are documented. And this is the image showing the choroid thickness was measured from the outer portion of the hyperreflective line corresponding to the retinal pigment epithelium to the inner surface of the sclera, known as the choroidal scleral interface. The 2 points are chosen in such a way that the line drawn between them is perpendicular to the RPE line. Measurements are typically taken beneath the geometric center of the fovea. Both the vertical and horizontal subfoveal measurements were taken, and an average of the 2 is considered as a final value. Image obtained with signal strength greater than 6 was considered. And the sample size was calculated using this formula, and we got 21 in each group. It was further increased from 21 to 31 in each group to document the contingencies such as non-response or recording error. And these are the following tests performed for statistical analysis in this study. And coming to results, 124 eyes were included in the study and 31 in each group. And these are the demographic characteristics of the study, which showed an increasing trend in the age, and a female to male ratio is equal in all the groups with a slight higher predominance of females. And the intraocular pressure and central corneal thickness was measured, and the intraocular pressure was found to be statistically significant on comparing the groups, and central corneal thickness was not significant statistically, but it was used as a correcting factor. And the mean choroid thickness among the study population was found to be increasing from primary angle closure suspect to primary angle closure glaucoma, and also comparison to controls. This is the plot showing the pairwise comparison of the mean choroidal thickness between the groups, which was found to be significant when compared to the controls, and on comparison between the groups. And this is and then the mean lens thickness values among the study groups was found to be significant when compared to the controls. But it was on pairwise comparison, there was no much difference between the groups, but it was found to be significant when it is compared to the control group. And coming to discussion, in the present study, choroidal thickness and lens thickness among primary angle closure suspect, primary angle closure and primary angle closure glaucoma and healthy controls were analyzed and compared. Most of the studies have demonstrated that choroidal structure and function may contribute to the pathogenesis of angle closure disease. And in this study, we used AIOCT to evaluate the macular choroidal thickness in different subtypes of angle closure disease. The subfoveal choroidal thickness in all subtypes of angle closure was significantly thicker than in healthy control eyes. We found that angle closure eyes had a greater baseline choroid thickness than healthy eyes. In addition to the shallow anterior chamber, shorter axial length, as said earlier, the choroidal thickness might be another anatomical characteristics of primary angle closure eyes. Greater baseline choroidal thickness may cause a greater tendency to choroidal expansion, which may be a risk factor. Choroidal enlargement is a dynamic feature seen in both untreated and treated acute and chronic angle closure disease eyes. An increase in the choroidal volume would lead to an increase in the posterior segment volume and pressure, which would cause the lens to move anteriorly and the anterior chamber to become shallower. An increase in episcleral and orbital venous pressure may cause choroidal enlargement. When the osmotic pressure of the extravascular choroidal stroma goes up, it leads to the leakage of big proteins that promote fluid flow into the extravascular space. The authors, in some studies, assume that initial angle closure represent choroidal growth in already tiny, physically predisposed eyes. Various studies have demonstrated that primary angle closure glaucoma have a substantially bigger and more anteriorly positioned lens compared to the normal eyes. In a study by Chakrabarti et al., different lens parameters were analyzed, and the mean lens thickness was more in all subtypes of angle closure disease compared to the control group and was statistically significant. These findings were similar to that of our study. It was also observed that there was a direct correlation between the increasing age and lens thickness, which again correlated directly with the shallowing of the anterior chamber. The onset of age-related lens changes could also contribute to the increased lens thickness and forward movement of the lens. My strengths are choroid thickness among different subtypes of primary angle closure disease was measured. Limitations were choroid thickness measurements were done manually, which could be subject to bias by the examiner. We measured only the subfoveal choroidal thickness, and dynamic measurements or changes in the choroid in other segments were not considered. Conclusion, primary angle closure disease eyes have increased choroid thickness and lens thickness than the normal eyes. Increasing choroidal thickness might be another anatomical characteristics of angle closure eyes. This observation may support the hypothesis that choroidal expansion is a contributing factor to the development of primary angle closure disease. My recommendations are automated segmental measurement software is want for a more objective evaluation of choroid thickness, and further studies with larger sample size and representing different groups of the population based on age, gender, race, and ethnicity can generate a normative database for choroid thickness measurement by EDI-OCT. Thank you.
Very good presentation. Any questions from audience side? I have one doubt. Do you have any correlation between iris thickness and choroidal thickness in your study?
But iris thickness was not measured, ma'am.
That plays a major role in angle closure.
Yes, ma'am. But correlation was not done, ma'am. We have to.
Vitreous length or volume? Did you measure? Lens to vitreous length?
Lens to
vitreous ratio.
That was not done.